everyone, and welcome to today's webinar. I'm Dr. Stacey Kitts, and I'm very happy to be moderating today's webinar. I'm an emergency physician at the Brandon Regional Health Center in Brandon, Manitoba. I'm the site lead for the University of Manitoba's Max Rady College of Medicine CCFP-EM training program, and the regional ER lead for COVID-19 for our Prairie Mountain Health region. Today's webinar topic was independently conceived by our Scientific Planning Committee, which is made up of Drs. Karat Gruel, Eddie Lang, Rob Stenstrom, and myself. My disclosures are as follows, and the other committee members also had no conflicts of interest to declare. This program received financial support from BMS Pfizer in the form of an education grant. All efforts were made to mitigate any potential biases. A little background on the webinar's development. In a recent needs assessment, almost 1/4 of surveyed EM physicians expressed a lack of knowledge and comfort in risk stratifying patients for stroke and initiating anticoagulation for stroke prevention in patients with atrial fibrillation in the ED. In addition, fully 80% valued CME in this topic. Given the various and often conflicting guidelines on this topic, there is often confusion around appropriate interventions. This topic is timely as CAEP is currently revising its atrial fibrillation checklist, which will be published in the upcoming months. Our speakers will be presenting the draft checklist during today's webinar. Our learning objectives are as follows. To increase the interactivity of this session, we encourage you to use the chat feature to submit your questions, and we will try to address as many of those as we can. We will also be doing some audience polling throughout the webinar, and for that you will need to have access to the Mentimeter website, which you can access via the website or this QR code. You will be prompted to enter the code on this screen and answer each question as it comes up. So you will be required to toggle between the webinar tab as well as the Mentimeter tab. And now, without further ado, I would like to introduce our speakers. Dr. Ian Steele is a professor in the Department of Emergency Medicine at the University of Ottawa, distinguished professor at the University of Ottawa, and senior scientist of the Clinical Epidemiology Program at the Ottawa Hospital Research Institute. He leads a productive team of emergency medicine researchers and chairs an internationally recognized emergency medicine research fellowship. He has published 433 peer-reviewed papers, including 30 in very high-impact journals. His major research initiatives have been in the development of clinical decision rules and resuscitation clinical trials. He developed the Ottawa Ankle Rules and Canadian C-Spine Rule and was the principal investigator for the landmark OPALS studies for pre-hospital care. His current research interests include acute atrial fibrillation and acute heart failure. Dr. Steele was appointed editor-in-chief of the Canadian Journal of Emergency Medicine in 2018. Dr. Claire Atzema is a staff emergency physician at Sunnybrook Health Sciences Center and a senior scientist at Sunnybrook Research Institute and ICES. She is an associate professor at the University of Toronto and a decision editor at Annals of Emergency Medicine. She has published over 100 peer-reviewed publications, primarily on care of cardiovascular disease within the emergency setting and transfer of care back to longitudinal care providers. Her primary focus is on atrial fibrillation, with a secondary focus on hypertension and heart failure. As a member of the Canadian Cardiovascular Society's primary AF panel, she has contributed to the CCS AF guideline documents since 2014 and has been a member of the CAEP AF Checklist Committee since its inception in 2017. And without further ado, I'd like to introduce Dr. Steele.
Thank you, Stacey, for that very kind introduction. And I'm very pleased to be here today. I'll just get my slides going, I hope. Right, are you able to see the slides okay? Great, okay, so atrial fib is one of my favorite topics, and Claire and I today will try to clarify the confusion. I've received an unrestricted research grant from Nkarta Therapeutics for less than $20,000, unrestricted in-kind contribution of vernaculant for a clinical trial from Cipher Pharmaceuticals, and I'm receiving an honorarium from CAEP for this presentation today. Why is rhythm control better than rate control? I think most emerge doctors in Canada accept that. It's better for the patient. The patient goes home quickly and in sinus rhythm, back to normal activities. There's no need to prescribe rate control agents on discharge, or not necessarily anticoagulants. It's better for the hospital. The patients leave the ED and are off monitors, usually in less than 6 hours, and it avoids unnecessary admissions. Last year, we published the large Canadian multi-center RAF2 trial, which showed that both drug shock and shock-only strategies are highly effective, rapid, and safe, and that 96% of all patients were sent home from the ED in sinus rhythm. We found that drug infusion works for 50% of patients, and it avoids resource-intensive procedural sedation required for electrical cardioversion half the time. So it's clear to us that immediate rhythm control leads to excellent outcomes. Late last year, the Canadian Cardiovascular Society updated their AF guidelines. And you'll see that my colleague Claire Atsema is on the panel, but it's a lonely job for her. The rest of the folks are cardiologists. We are a bit disappointed that they did not more widely consult with emergency doctors. We don't agree with quite everything that they suggested. And we were a bit disappointed that they dropped the previous ED management chapter. So this is where we believe the CAEP acute atrial fibrillation and Flutter best practices checklist can fill the void. We originally published this in 2018, and we had a panel of emergency doctors and cardiologists. And this has now been updated. We've recently completed our discussions, and we will be publishing the 2021 update very shortly. So today I'm going to try and give you a sneak preview of some of what we have decided is best practices. So this is the overall algorithm, obviously very busy, so please don't fuss about the details. There's 4 chunks: top left, assessment and risk stratification; bottom left, rate and rhythm control; bottom right, stroke prevention, who needs anticoagulation; and top right, disposition and follow-up. When we consider assessment and risk stratification, there's several questions you have to ask yourself. Is the rapid rate due to a medical cause? Is the patient unstable? Are they adequately anticoagulated or otherwise safe for cardioversion? One of the first questions to ask yourself is the rapid AF that you see on the monitor, is this a primary arrhythmia, or is the rapid rate secondary to a medical cause in a patient who has permanent AF? And the medical causes could include sepsis, bleeding, pulmonary embolism, heart failure, ACS, etc. And the learning point here, and it's a really key one, is that you should treat the underlying causes very aggressively. And these patients who are in permanent AF, cardioversion will be ineffective and could be harmful. And we also suggest you avoid aggressive rate control, again, focusing on the underlying medical problem. On the other hand, primary arrhythmia is the sudden onset of AF or paroxysmal AF that we often see in the ED. We have sections on rate and rhythm control, advice if you do have to go with rate control, and we talk about optimal electrical and pharmacological management for achieving cardioversion, as well as what to do with a WPW case. So, is it safe to cardiovert? In all cases, if the patient's been adequately anticoagulated for at least 3 weeks, it's safe. The rest of this gets tricky. It's more complicated than it used to be. So I'll take a moment to explain it to you. So if the patient's not anticoagulated, it's still safe to cardiovert. If they have no history of stroke or TIA and no known valvular heart disease, if they come in less than 12 hours of onset, you're good to go. If they're between 12 and 48 hours, however, you need to be aware of possible comorbidities, the classic CHADS 65 criteria, and you want the patient to have 0 or 1. If they have 2 or more of these criteria, then it's not safe to cardiovert. The third way that you can safely proceed is if you're super lucky and have access to transesophageal echocardiography, which most of you do not. So for some patients, it's not safe to cardiovert, so you have to go with rate control. We recommend first-line calcium channel and beta blockers. A tip, if the patient's already taking one or the other at home, well, then that's the way you go. Calcium channel blockers, avoid of heart failure. Big problem that emerge docs commonly share, and this used to be me too, is that we're not aggressive enough in the first hour. Our panel recommends that you give 3 doses of diltiazem or 3 doses of metoprolol in the first hour. And if you're getting rate control, then you start oral of the same right away. Second line is DIG, and it's much slower. It takes 12 hours or more to get the rate down, but it may be the best way to go if the patient's hypotensive or an acute heart failure and you're uncomfortable or recommended not to use CCBs or beta blockers. Remember that your goal is to get the heart rate down to less than 100 if they're in bed. And if you're sending them home, it'd be nice to keep it under 110 while they're walking. Rhythm control. So either pharmacological or electrical cardioversion is acceptable according to patient and physician preference. The RAF2 trial compared drug shock approach, which is procainamide, then followed by electrical cardioversion if necessary, and the shock only strategy where you just start with electrical. We don't recommend pre-treating with rate control agents. It's just a waste of time. For procainamide is our drug of choice. We recommend putting it in 500 of saline over 60 minutes. So run it a bit slowly to avoid hypotension. We absolutely do not recommend amiodarone in the ED for the type of patients that we see. It's ineffective. And these are quite different from the patients seen in the ICU or in post-op recovery. Other options that are not commonly used in Canada are IV vernaculant, IV ibutylide. Electrical cardioversion, you need 2 nurses or a nurse and an RT. Another doctor is ideal, but it's really not necessary. And you can go with whatever guidelines you have at your local ED for any procedure that requires sedation. We notice that most Canadian doctors use propofol. In terms of the pad and paddle position, the RAF2 trial found that either anterolateral or AP are acceptable. They're equally effective. We recommend you start high at 150 to 200 joules. And many patients can be discharged as soon as 30 minutes after electrical cardioversion. Who needs long-term anticoagulation? This is fairly straightforward and hasn't changed much. Bear in mind that if you send somebody home on anticoagulants, it's for long-term stroke prevention. And the CHADS 65 algorithm that was introduced in 2014 by CCS is what you should hang your hat on. So if the patient has any of these 5 characteristics, stroke, age 65, diabetes, hypertension, or heart failure, then it's on you to prescribe oral anticoagulant at discharge. Obviously, you want to use shared decision-making to include the patient's preferences. Coronary disease, you might want to discontinue. You should discontinue aspirin. If they're CHADS 65 negative, CCS suggests 4 weeks of OAC after shared decision making. This is a weak recommendation based on low quality evidence, and our panel at CAEP are not super thrilled with this recommendation. So you talk it over with the patient. We find many young patients just aren't interested on going on oral anticoagulants for 4 weeks. Bear in mind, if the patient comes in an AF but spontaneously converts, then you also have to apply the CHAD65 algorithm to see if they should be considered for OAC. What are some of the contraindications to anticoagulation? Our colleague Kirsten DeWitt at MAC, formerly of MAC, developed this really nice checklist that we recommend and will be in our new guidelines, is when it is and is not safe to prescribe oral anticoagulants. Which anticoagulant? Well, in this day and age, DOACs are definitely preferred. There's still a role for warfarin with mechanical heart valves, moderate to severe mitral stenosis, or creatinine clearance less than 30. We don't often prescribe DOACs in the ED, so it might be nice just to learn one. We don't recommend any one over the other. They all work well, and an excellent reference is the Thrombosis Canada app. This is free and gives you all the details you could ever want about dosing of these agents. In terms of disposition, rarely do patients need admission, rarely. If you can't get their symptoms under control by slowing them down, or if they're having clear ACS or their heart failure is not clearing, then you might require admission, but this should be less than 5% of these patients. Patients should be seen quickly if they're put on warfarin or new rate control meds. Otherwise, we suggest that they can be seen by cardiology or medicine sometime in the next 4 to 6 weeks. So from our point of view, the bottom line is that almost all acute AF patients can be cardioverted in the ED and sent home quickly. So I'll be happy to take a question or two before we move on to Dr. Atsuma's segment of the presentation.
Just one question so far from the audience, and that is how does the panel prescribe oral calcium channel blockers? What sort of dosage are you using?
That it will be in the document. I left it out of the slide, not wanting to overdo it, but we will give you a recommendation of either short-acting or extended release calcium channel blockers, as well as for beta blockers. So just stay tuned. It's coming.
One follow-up question, why is the CHAD65 and not CHAD's VASC score being used?
Okay, so 2014 and went to the CHAD65 algorithm that was developed by this Canadian Cardiovascular Society. I think they don't like the fact that CHAD's VASC incorporates female sex, for one thing. And so CHAD's VASC, as far as Canadian emergency doctors is concerned, is obsolete and should not be used.
Okay, excellent. And because we have time for one more quick question, is there a role to use diltiazem infusion rather than 3 bolus doses?
We don't recommend that. No, it takes too long. Well, I mean, you don't. Each dose is given over 10 minutes, so it's it's like in a little baggie is usually how our nurses do it. So it's 3 slow, quick infusions. How's that?
Sounds great. Thank you very much.
Thank you. So I will pass the microphone over to Dr. Atsuma.
Okay. Here we go, sharing screen. Can everyone hear me? Jeff, can you hear me? Great. Excellent. Okay. So now that everyone in the audience is on the cutting edge with respect to AFib CAEP checklist, which hasn't even been published yet, soon to be out. I'm going to take all that information you just learned from Ian and try to apply it to some clinical cases. AFib care is constantly changing and it's very complex. And often you hear a talk and you think you've got it, and then you're presented with a specific patient and you realize you didn't quite grasp all the nuances that you thought you did. So we've specifically chosen 4 cases that will highlight some of the confusion and hopefully take it out of your practice. So I am funded by CIHR and Heart and Stroke, as well as my practice plan at Sunnybrook Research Institute and the practice plan at Sunnybrook and the Department of Emergency Services. And I think I'm getting it on our arm from CAEP as well. So again, there's going to be some questions. You can go to www.menti.com and use this code to answer the polling questions. So case number 1 is Jack. And in fact, I'm going to use Jack for my entire presentation. We're going to have 4 cases. They're all Jack, and I'm just going to alter one element at a time of the symptoms or the medical history to keep it very simple for you. So just one element changing at a time. In the meantime, Jack is a 67-year-old man with sudden onset palpitations for 6 hours. Now it's still ongoing and no other symptoms. So he has a heart rate of about 150-ish. It's irregular, so it's bouncing around. His pressure is good. His exam is normal, except for his irregular tachycardia. His past medical history is hypertension, for which he takes amlodipine. And on the ECG, you see clearly it's an irregular rhythm. It's AFib. So the polling question, if you can go to it now, is Jack a candidate for cardioversion? Again, he's 67. He's had this for 6 hours. And he has a history of hypertension. So you're going to use the CAEP checklist that Ian just highlighted to determine, just to get us warmed up here, is he a candidate for cardioversion? And I'm told that it's going to take about 30 seconds for everyone to see this. So I'm going to try to do something to entertain you, not the interpretive dance version of AFib, but rather just to say that things change from you can do it for everyone within 48 hours in 2018 with the publication of the first CAEP AFib checklist in 2018, as well as the CCS 2018 AFib guidelines. Prior to that, everyone, if it was within 48 hours, as long as they didn't have valvular heart disease or a recent stroke, meaning within the last 6 months, they were good to go. But that's all changed as of 2018, and that's because of the FIN-CV study, which suggested, it wasn't a great study, but it suggested that a longer duration of AFib was associated with higher risk of subsequent stroke. So instead of being low risk up to 48 hours and then suddenly it's much higher at the turn of 48 hours, probably it's just gradual. The longer you're in it, the higher your risk of subsequent stroke. Okay, so 82% would say he is a candidate for cardioversion, 83% are still going a bit, and 16% would say no. Okay, I'm gonna go from there, I think. So we're going to ask the questions that you saw Ian present to you. And if you have the figure, I'm going to go through that as well next. You know, we know that he's not unstable. So I'm going to start with, does he have a history of valvular heart disease or a history of stroke? And Jack does not have either of those things. So we're good to go from that perspective. Now, if we made our way through the figure to the next box, we would say, is the timing less than 12 hours? And yes, it's at 6 hours. So we are good to cardiovert this patient should we choose to. And again, if you have this in your pocket or on your phone, you can quickly look at, does he have rapid AFib secondary to medical cause? No. Is he unstable? No. Has he been anticoagulated for the last 3 weeks? Well, no, he's never had AFib before. So why would he be unless he had VTE? And does he have a history of valvular disease or a prior stroke or TIA? No. And by valvular disease, we mean anyone with a history of mechanical heart valve or mitral stenosis that is moderate to severe. That's it now. It has changed over the years and it's obviously pretty confusing, but it is now mechanical heart valve or moderate to severe mitral stenosis. We don't care about the other valves. He doesn't have either of those. It was less than 12 hours ago. It was at 6 hours, so we can cardiovert him. And we do, and he goes back into normal sinus rhythm. And the next polling question that we need to ask ourselves to care for this patient, is he a candidate for oral anticoagulation? So I'm going to, again, I'm told it takes a little bit for everyone to see this, so I'm going to talk a little bit but just reminding you, he's 67 with a history of hypertension. He is back in normal sinus rhythm now. He doesn't have those terrible palpitations anymore. He feels great. He's happy to go home. We went home 30 minutes after the cardioversion because the procedural sedation with the propofol wore off. So now we're thinking, is he a candidate? And of course, if he is a candidate, the other factor is, well, could you just send him back to his longitudinal care provider, his family doctor or cardiologist to start it up? And, I think that's a very relevant question that many of the cardiologists don't seem to understand why we wouldn't just start it ourselves. Well, we don't see these patients again, and we're starting them on a blood thinner. But my team and I did some research. One was some studies. One was published in CMAJ, which showed that if you start the oral anticoagulation, a year later, that patient is much more likely to be on it than if you refer them back to their family doctor or their cardiologist to start it. And so you actually have a real impact to affect someone's life, to prevent them from having a major stroke, because strokes from AFib really are major. They have a 50% mortality rate at a year. So it's an opportunity for you to really impact someone's care. Okay, so most of you, 84% said yes, he is a candidate. And indeed, you are right. So we're going to use the CHAD 65 algorithm, which you heard Ian talk about. And I'm going to show the figure in a moment, but basically it's an algorithm. It's not points anymore. With the CHADS 2 and the CHADS VASC, it was points, but it's an algorithm, and it starts with age. Everybody over 60 or 65 and older should be on it. They are high enough risk of a stroke at a year that you want to give them oral anticoagulation in order to prevent them from having that stroke. And particularly if you have cardioverted a patient, they're at a slightly increased risk from atrial stunning, from all the inflammatory mediators that occur. Sorry, I'm speaking fast. Get going. When they're cardioverted, so that is even a slightly increased risk for the first couple of weeks after cardioversion. So you definitely want to make sure Jack is put on an oral anticoagulant, and he's over 65, so it's already a done deal. He also has hypertension, but with the algorithm, you don't even need to follow. So here's the algorithm, the CHAD 65 algorithm. You can Google it and find it really easily. He is over 65, so we're going to put him on oral anticoagulation. As I said, he also has hypertension, but he already qualifies. The only time aspirin, or that yellow box of antiplatelet therapy, comes into play is if they have nothing else and they have coronary artery disease. Just like most people with coronary artery disease should be on aspirin to prevent them from having a future AMI, for example. That's the only time the committee wants them put on aspirin. Aspirin is not a great treatment for atrial fibrillation to prevent strokes. So now the question is, all right, we're going to put them on oral anticoagulation, and everyone wants to know, well, which one? So in general, as Ian mentioned, DOACs are better than warfarin. They have less bleeding. In particular, they have way less intracranial bleeding, the ones that we really don't want to have happen to our patients. So they are safer than warfarin, and some of them are actually even more effective than warfarin. There are two scenarios where warfarin is still has to be used and not a DOAC, but mostly you don't need to remember these, but I'm going to mention them here just for the sake of being complete. And that's in patients who have a low GFR. So they're actually between 15 and 30, you can use apixaban, and they are starting to use apixaban. But even lower than that, they're only to use warfarin, but you're not going to be starting oral anticoagulation in patients with renal failure. Just give them to someone else, call a consultant. You've got 10 other patients to worry about. And then the other area is if the patient has valvular disease, warfarin is indicated. You don't use DOACs in valvular disease. At least at this point, the evidence shows that they're worse in valvular disease. So again, moderate to severe mitral stenosis or mechanical heart valve, we don't use DOACs. Tissue valve, like a bovine or equine or porcine valve, those you can use DOACs. But if you're getting into that kind of nitty gritty, just call somebody. You don't need to know everything about everything. This is sort of minutia, I think. But just to keep aware, there are two scenarios where we do want to continue using warfarin. So these are the DOACs, direct oral anticoagulants. They used to be NOACs, but it wasn't really very forward thinking because they, after a while, are not going to be novel oral anticoagulants. They're just called direct. So if you want to use the right term, it's actually DOACs. And these are the four we have on offer. And I could just leave it at that and say, get to know one, which Ian already pointed out is the best way to do it, and choose that one or two, maybe once a day and a BID. when I go to a talk and I see someone else who speaks my language, it's like they're an emerge doc and they've researched a whole area, I want to know, well, what do you actually use? Because you've researched it, and tell me what you use. And if they don't, I feel like it's a bit of a cop-out. So I'm going to tell you what I use, but it's just my personal sort of what I've gotten to know. And so what I ask myself first is this patient elderly or are they frail? Because if they're elderly or looking very frail, I generally use apixaban. If they're elderly, they're probably on a ton of drugs anyway, some of which will be BID. So it's not a big deal for them to have a BID drug, which apixaban is. It's been shown to be more effective than warfarin in the Aristotle trial. Most of them were equivalent, but in the Aristotle trial, it was actually more effective at preventing systemic embolism and strokes. And elderly people are at higher risk of strokes. They're also at higher risk of bleeding, but they're at even higher risk of stroke. So I generally reach for apixaban. It also has less major bleeding than the other DOACs. So apixaban for my elderly frail. However, Jack is not elderly or frail. He's 67. He looks good. So then I asked myself, well, is he already on a BID drug or is he only on once a day meds? And he's on amlodipine, which is once a day. So we want to really encourage good adherence. The half-life of the DOACs is relatively short. It's not like warfarin. If you miss a dose, your INR goes down slightly by a day. If they're consistently missing doses, they're going to be at increased risk of having a stroke. So given that, we want them to take their drugs very regularly. If they're already on once a day, don't give them twice a day. Like, that's hard for them to remember, and they may miss drugs. So make it as simple as possible. Encourage adherence by choosing a once a day. That's what I do anyway. So in Jack, I would choose a once a day, which leaves me with either rivaroxaban or edoxaban. The only thing that I think about when I am using edoxaban is there are this small group of people who have their super clearers. So their creatinine clearance is super high. It's above 95 mils per minute. And so if you have someone with a super clearance, they can clear out the edoxaban and it might not get them anticoagulated enough. So I do check the creatinine clearance if I'm prescribing edoxaban. And the way you do that is you use the Cockcroft-Gault formula. And you probably vaguely remember that from med school. The number that you get on your lab is using the creatinine clearance that you get spit out from your lab is using a different formula. And in fact, you'll have them not meet about a third of the time if you use Cockcroft-Gault compared to what the lab is using. And the reason Cockcroft-Gault isn't any better than, in fact, it isn't as good in some ways as the other formulas, but that's what the product monographs use. So you want to be consistent with what the product monographs recommend. So that's why I use Cockcroft-Gault formula. And I just Google it, Cockcroft-Gault formula calculator, and I stick in the elements. And I just want to make sure that it's not over 95 mils per minute, which I've never had anyone who was yet. And then I know that they're not going to clear out the edoxaban. So I'm going to start Jack on one of those two. This is from the 2020 AFib CCS guidelines. And basically, it shows you what you should be using, but you can use the Thrombosis Canada app that Ian Steele recommended, and that will tell you exactly what you need to use. Basically, if Jack had a lower creatinine clearance, I would go down on my edoxaban or my rivaroxaban. With apixaban, it's actually kind of nice because they don't use creatinine clearance. They just use serum creatinine. And I know it's only one extra step, but as emerge docs, we're so pressed for time, and having to calculate it or ask what their weight is a pain. So with apixaban, you just have to look if they have two of these three, age over 80 or body weight is less than 60 or serum creatinine above 133. If they have two of the criteria, then you would bump down the dose. Don't bump down the dose if they don't have these things because you're nervous about starting an anticoagulant, because then all you're doing is not properly protecting them from having that big stroke. Plus they're now at increased risk of bleeding. So you want to make sure that you're giving the right dose. And anything less than 29 or 30, I mean, honestly, I don't even know if I would even bother with 30 to 49. I might just call my consultant to let them deal with it. I've got other patients to deal with, but certainly lower than that. If their renal failure causes the DOAC to build up, then they're at increased risk of bleeding. And we don't see the patients ever again. So on the committee, the AFib CAEP checklist, we said, just don't even bother if it's below 30. It's not our purview. We're not going to be following these patients. So I think I saw quite a few questions, and I will turn over to Stacy.
The questions have been coming in fast and furious. So another question about CHAD 65. It seems like the difference between the Canadian Cardiovascular Society versus CAEP on the risk stratification is that the Canadian Cardiovascular Society uses CHADS 2 versus us using CHAD 65. The question is, why did the CAEP panel choose CHAD 65?
So for oral anticoagulation, for choosing who needs to go home on oral anticoagulation after cardioversion is done, or you didn't even bother cardioverting a patient, everyone only uses CHAD 65 in Canada. That's all you should be using, not CHADS VASC, not CHADS 2, just CHAD 65 tells you, do I put them on oral anticoagulation or not? For cardioversion, yes, there is a difference between the CAEP group decided to not confuse things by going back to CHADS 2. And so you just have to make your way through the elements to figure out, is this person a candidate for cardioversion? And we're going to go through some more to highlight some of those nuances. Whereas the CCS, and I will highlight when they would come out with something different, because they're two of the cases they do come out with something different. They start out with, if it's above 12 hours, then go to the CHADS 2 risk factors. So that is slightly different because in CHADS 2, there's no age between 65 and 74. It's only age over 75. So they say less than 2 of the CHADS 2 risk factors to decide if you're going to go on a cardioversion. We said this is just too confusing to have too many algorithms or risk scores to go to, and we just listed them there, the factors inside the algorithm. But I'm going to go through that just to highlight those differences, I promise.
Okay. I think to keep things moving, we will save some of these other questions to the end.
Okay, great. Okay, so here is one of those situations. Thank you for whoever asked that for leading us into this next one. So what if he also had a history of stroke in addition to hypertension? So here's Jack again. He's just the same, just got the palpitations, but he's got hypertension and a history of stroke that he had 5 years ago, the hypertension he's had for 10 years. So he's on amlodipine and aspirin. So let's get difficult here. Is Jack a candidate for cardioversion? So it's 6 hours. He has a history of hypertension and stroke. Stroke happened 5 years ago. And here, don't feel uncomfortable if you get it wrong, because it would really depend on which guidelines you are going to follow. This is one of these, most of the time they're going to be consistent, but there are a couple of scenarios which we're highlighting here just to directly address the elephant in the room when they're going to end up slightly different or with a different outcome for cardioversion. So the majority are saying no, he is not a candidate for cardioversion, and 25% say, 30% say yes. And that's actually, I mean, it makes a lot of sense considering what's out there. So we're asking our first question. We've decided he's not unstable, he doesn't have a secondary medical cause for AFib. The first major question when you have a primary AFib patient who's stable is, does he or she have a history of valvular disease, as we define it, or a history of stroke? And he does. So we are not going to cardiovert this patient according to the new CAEP best practices checklist. Now that said, just as the person who asked, for cardioversion, the CCS guidelines uses the CHADS 2 risk factors. And they say, I don't really want to go into all of theirs, but they say if they have a history of stroke in the last 6 months, you cannot proceed. So a recent history of stroke or TIA. They don't say any stroke. So then you'd go on to the CHADS 2 risk factors, which anyway, I'm not going to go into it too much because I don't want to highlight theirs, but you, for the CAEP AFib checklist, we're saying any history of stroke as opposed to the CCS guidelines, it's only a recent in the last 6 months that it would take you out of even further consideration.
Claire, I'm going to butt in here.
Okay.
So the panel is really worried about confusing emerge docs. And so we have made the decision, as you just explained again, that if they've had a stroke or TIA ever, that they're not safe for cardioversion, assuming they're not already anticoagulated. And I'm hoping that would be the take-home message for folks, and that they should, when the CAEP guidelines come out, they should feel safe and comfortable following them, because they've been debated at length by a number of experts and externally audited by many more experts, so that if it's in this new CAEP checklist, it's absolutely safe. And as you say, it may even be a little more cautious than what the CCS guys say.
Yeah, so you're being slightly more cautious by following the CAEP guidelines. And so again, just if you had this figure on your phone and you're looking at it, trying to assess, is this patient a candidate for, is this Jack, who's had a history of stroke, a candidate? Does he have a secondary medical cause? No, he's not unstable. He's not been anticoagulated. Does he have a history of valvular heart disease or a prior stroke or TIA? Yes, he does. So we are going to put him on rate control and start him on oral anticoagulation and refer him to someone else who can reassess in 3 weeks or more whether or not he should be cardioverted at that time. And that's a perfectly safe option. It's always an option. I think emerg docs are very scared that if they don't do it immediately, that the patient is going to be forever stuck in AFib, because AFib begets AFib. But you know, that process needs like 3 months, 6 months, actually well over 6 months for them to get stuck in AFib where no one else can cardiovert them back. So for this Jack, we're going to do the usual and send him to a cardiologist who can then refer him to an EP clinic where they can cardiovert him in the EP clinic. So now we're getting into some tough stuff. This was debated a lot in the committee as well, as we should not even put this in there, or should we address it? And many of us on the committee, including Ian and I, asked colleagues, do you want us to keep this? And they do want to talk about patients who are on aspirin and how you manage that. So I'm going to directly address it, but I'm going to preface that as you turn to the polling station, please go to the polling station, that, you know, if you're at all uncertain, just call someone. That's what consultants are for. That's their whole job. That's why you're in a hospital that has a consultant, whether it be an internist or a cardiologist. They have more time to figure out if they should stop or continue the aspirin in addition to starting the DOAC. So that's always a very, very valid option. We're just addressing it here to make sure that we address everyone's questions. So you're going to start him on a DOAC because he qualifies according to the CHAD 65 algorithm. What are you going to do about that aspirin? And this one's tough. I struggle to remember it. And I've read this guideline so many times. All right, we have about 80% who are going to stop and about 20% who are going to continue the aspirin along with the DOAC. So let's back up. We know that he is a candidate because of the age, the hypertension, and the stroke. He's not elderly. He's on once a day meds. So we're going to start either rivaroxaban or edoxaban. But now we get to the bottom line 3 there, where is he on aspirin? And this is what I asked myself, or is he on ticagrelor or clopidogrel, another antiplatelet? So dual antiplatelet therapy means either ticagrelor or clopidogrel along with a DOAC. And there's very few clinical scenarios where that should be happening. And there's even less when there's triple therapy, which would be DOAC, ticagrelor or clopidogrel plus aspirin. So that's a 1 month scenario following PCI or an acute coronary syndrome. So that's almost never that you're going to see someone who needs to stay on all 3 following an AMI, an ACS episode and a PCI. And that's really how the only scenarios where you would need more than just the DOAC is if they have had ACS, an acute coronary syndrome, or they had PCI in the last 1 year. Now, there are details around high risk factors that you don't need to know, but if you really want to know about aspirin and or clopidogrel or ticagrelor, you just ask yourself, and this is how I keep it simple for me, have they had an acute coronary syndrome and or a PCI in the last 1 year? Because if they had, then maybe they do need to stay on clopidogrel in addition to the DOAC I'm starting, and then I'm calling someone else to deal with it. Or, you know, personally, I do start it, but that's because I'm pretty comfortable with the guidelines having been on the committee. But that's the only time. Every other time, we do not want to keep them on dual antiplatelet or, God forbid, triple antiplatelet because they're at very high risk of bleeding. And Jack has not had acute coronary syndrome in the last year, and he's not had a PCI in the last year. So I know that I'm going to stop the aspirin and I'm going to start either rivaroxaban or edoxaban. Again, if you're confused, call your consultants. That's what they're for. You have 10 other patients on the go. You're way too busy for this. Everyone would love it if we as emerge docs did everyone else's jobs, but at some point we have to say no and get on with the emerge patients. All right, so case 3 is still Jack, but what if he had a history of diabetes instead of stroke? So here it is. He's got diabetes and hypertension, so he's on amlodipine, metformin, and glycoside, and it's still been 6 hours of palpitations only. And I'm just going to whiz through this because it's a little more simple. So is he a candidate for cardioversion? Does he have a history of valvular disease or stroke? No, he does not. He only has a history of diabetes and hypertension. So we can go ahead. Then we ask, is the timing less than 12 hours? Yes, it is. It's still 6 hours. So we can go ahead. And then once he's cardioverted, he's back in sinus. Just because he's back in sinus doesn't mean he doesn't need oral anticoagulation. He absolutely does. Many patients can't even feel when they're going back and forth briefly into a fib. And there's pacemaker studies which show this. So we're still going to use a CHAD 65 algorithm, and we've already worked through it. He's over 65. We're done. He needs to be on something, probably a DOAC. All right, last case. So what if Jack had presented to the ED after 14 hours of AFib instead of 6 hours? And this is where it does get a little confusing. And you can always pull out the AFib checklist, the CAEP AFib checklist, and take a look. So it's been 14 hours, and it's the original Jack who just has hypertension, and he takes amlodipine for that. All right, everyone. Final polling question, I think. Is he a candidate for cardioversion? He's at 14 hours, so he's over that 12-hour deadline. And he has a history of hypertension, 67-year-old man. I'll give everyone a minute and I'll stop having to stop talk so everyone doesn't have to listen to me. Okay, so around 80% are saying no, he's not a candidate for cardioversion, and around 20% are saying yes. And again, it depends what guidelines you're choosing to follow. But if you're using the CAEP AFib checklist, then the answer is indeed no. And if we make our way through, does he have a history of valvular disease or stroke? Step 1, he does not. This is only hypertension, Jack. Okay, so we can go ahead. Next question, is it less than 12 hours? No, it's 14 hours, maybe it's 16 hours by the time we actually saw him after he presented as the emerge doc. So now we need to go to the next line, which I'll show you in the next slide. Is the onset between 12 and 48 hours? Yes. And does he have less than 2 of the following? Well, he is age over 65, so he gets one of those. He doesn't have diabetes, but he does have hypertension. So he has 2 of those things. It's not less than 2, so he is not a candidate for cardioversion using the CAEP AFib best practices checklist. Boy, that's a mouthful. Now, if you had used the CCS guidelines, 2020 or 2018, you would find that he is a candidate because they're using CHAD's 2 score of less than 2. And CHAD's 2 score does not count age 67. Age in the old CHAD's 2, if you think way back to when we used to use it, is 75 or older. So using that guideline, you might end up arguing with your cardiologist. And it's not that either of you is wrong, it's that there's these slight variations and CAEP is slightly more conservative. And I think that's always kind of the safer place to be, quite honestly. But just to address the elephant in the room, if you find yourself arguing with your cardiologist, this may be why. So going through the little figure again that you can pull up on your phone, he's not unstable, he's not been anticoagulated, he doesn't have valvular heart disease or a prior stroke or TIA, just hypertension. Was it less than 12 hours? No, it was between 12 and 48 hours, but he doesn't have less than 2 because his age qualifies as well as his hypertension. Now, if you're so lucky to be able to get a TE, like I know almost nobody, you can get a TE, but if you can, and God knows why you'd want to go through that whole procedure. It looks bloody awful. Just to avoid being on rate control and oral anticoagulation for 3 weeks before you get seen at an EP clinic to get cardioverted. I don't know, but if you want to do that, you can do that. So that just means rate control for him. All right, last slide. And Ian, and someone already asked this question. And CHADS VASC is and I got asked about this in a CCS presentation I did, Canadian Cardiovascular Society presentation I did on Friday. It's amazing how many people are asking it. CHADS VASC does not exist in the Canadian guidelines anymore, either the CAEP guidelines or the CCS guidelines. If you do a search of the entire CCS AFib guidelines, you'll only find it being referenced in previous AFib guidelines. So we stopped using that in 2012. So from 2014 onwards, we're just using CHADS 65. And when I first started with the CAEP guidelines, I actually thought I preferred CHADS VASC because it sort of outlined everything. But you'll notice that, and Ian has already pointed this out, that females are not put in the CHADS 65. You don't see females anywhere. And the reason for that is the risk for having a stroke annually, if you're female, is about 0.7%. We don't want to condemn people to a lifetime of taking a pill and a blood thinner unless their risk of having a stroke over a year is well above 1%, say 1 to 1.5%. So the CCS committee said just being female, if you're under 65 and have nothing else, is not enough to justify putting someone on an oral anticoagulant for the rest of their life. And initially, the Europeans, the ESC, and the Americans said, well, we will. But then over time, they've actually come around and decided, no, we agree with you. Women shouldn't be by themselves enough to put on oral anticoagulation. But they were stuck with this CHADS VASC that everyone was using, and they didn't want to change. So they stuck with it, but then they had to give different point scores for males and females. So if you use this, you have to figure out which score you're going to use if they're female versus they're male. Not to mention you could be giving aspirin or OAC or nothing with a point of 1 for males or 2 for females. And aspirin is not good for preventing strokes in AFib. It's only for people who only have coronary artery disease. And using this score, anyone who has 1 point, like just diabetes, could end up on aspirin. And that's not good care. So please stop using, there's my big X, don't use CHADS VASC. It's not in the Canadian guidelines territory at all. Okay.
Well, that's excellent timing, Claire, because I was just about to cut you off.
Good.
There are a number of questions, so hopefully we can get through some. The first question is, there was a recent JAMA cardiology study contradicting that oral anticoagulants under 64 is over 64 is universally warranted as the stroke risk gradually increases between 65 and 75 and doesn't really meet significant risk starting at 65.
So I just looked this one up because I'm not familiar with it. The author's name that was suggested is actually the guy's first name, so it took a bit of hunting to get. This study is from Toronto. It's an ISIS style study looking at administrative databases, and I don't really get their point. So they said that the risk of having a stroke increases gradually from 65 to 75. So exactly. So the CHADS 65 algorithm, which is wholly endorsed by CCS, says at age 65, you should start anticoagulating people if they've ever had AF, because the risk is increasing. So I don't think that this new study, I think it actually concurs with what we're currently doing. So I wouldn't worry about it myself. But congratulations to whoever found that article. Obviously, you're on top of the literature.
And then
there's another question I just thought I'd quickly answer about the app. Yep. So we had a beautiful app we created after the 2018 guidelines, both in English and French, free of course. And so now we will recreate that app. I'm gonna have to scrounge around to find the money to do it because our original grant has run out, but we for sure will do the app because, we're going to publish this thing, but you're not going to carry it around in your pocket. We do hope to have the guideline on the CAEP website, so readily accessible is our goal. And plug for CGEM also is that our Just the Facts series and these kind of guidelines will be readily accessible to anybody on the CAEP website. It would be another way to just quickly get it.
Okay, thank you. And there's a question about, is there merit to starting with a higher energy level for cardioversion? There was another study cited in the question box.
Well, I think we already said that, that we start at 150 to 200. In Ottawa, we always start at 200. I don't know if they still do it, but the old ACLS guidelines were kind of weird because they had you start at 75, 100. You know, by that time, the guy's awake. So with propofol, we want the shock to succeed. Now, if your device goes to 360, you can certainly go higher than 200 if you want to, if that answers the question.
I think so. And another question about edoxaban. Can edoxaban be used down to a GFR of 15 at 30 milligrams rather than warfarin?
Oh, that's that Claire question for sure.
15. You know what? I mean, I think it is. I've not ever seen it used. I think there is some evidence coming out to say that it could be, but you should not, as an emerg doc, be starting edoxaban. I mean, unless you're a cardiologist or an internist or even a family doctor, like I would have a nephrologist on board. Like, this is not something that you want to start someone on, have their renal failure get worse, and then they have a buildup of an anticoagulant in their bloodstream, and then they have a major bleed, and they come back 3 weeks later, and you're the doc on to take them with their major bleed. So I wouldn't even go there, honestly. I wouldn't.
I think the data for you showed in your chart earlier, Claire. So there's very little data on it, so you can't say. And I had one of our cardiologists read the checklist last week, and he said, "What are you even talking about warfarin for in renal failure? Like, it's not safe there either." So
yeah,
you got
there is
renal
evidence
failure.
It's just what's always been used, basically.
Talk to the experts. Yeah.
Yeah.
Why are we still using warfarin for valvular heart disease?
Because in the big trials,
the
Aristotle trial and the Rocket AF, all those big DOAC trials, it was found to be worse with patients with valvular heart disease. So that we don't use it for that specific definition of valvular heart disease, which is moderate to severe mitral stenosis or mechanical heart valve. So it was found to be worse.
Okay. Well, excellent. Thank you, everybody. I think we're just coming up on the hour, and that's probably all the time we have for questions. I'm sorry if we didn't get to your question. Thank you very much to Dr. Steele and Atsima for the very informative talk. You have helped clarify the confusion. This session has been accredited by the College of Family Physicians of Canada and the Royal College. So don't forget to fill out your evaluation form and claim your credits. A certificate of attendance will be mailed out by CAEP together with the evaluation link. Finally, CAEP has a very interesting lineup of live and on-demand educational webinars planned in September. So please keep an eye out for more information and plan to join us again in the fall. Thank you very much for joining us today, and please stay safe over the summer.